Vijayawada. All are very familiar names to all of us who practice ROP. So we are hoping for a very nice and a very interactive session here. I would request all of the participants to post their questions on the chat. And we'll start off with the cases. So the first case is by Dr. Aishwarya, who is who's a junior resident at AIIMS, New Delhi. So Dr. Aishwarya, welcome. And can you please share your slides?
Good evening, everybody. I'll just be sharing my screen.
Yeah, go ahead, Aishwarya.
Yeah. Am I visible and audible?
Yeah.
Yes.
Okay. So good evening, everybody. I'm Dr. Aishwarya Shashi. I'm a second-year resident at RP Center, AIIMS, Delhi. And today I will be presenting a case of aggressive retinopathy of prematurity. Our patient was a 30-week preterm baby who presented to our retinopathy of prematurity clinic at RPC at 34 plus 5 weeks of postmenstrual age. The baby had a birth weight of 1.5 kg and was delivered by normal vaginal delivery. The baby had been screened outside and had been diagnosed as both eye aggressive retinopathy of prematurity extending into zone 1 with the presence of plus disease. On further history, the baby had the following systemic risk factors which could have predisposed to ROP. The baby, of course, had a history of prematurity, and the baby had a very low birth weight of 1.5 kg. The baby also had a history of respiratory distress syndrome, which necessitated NICU admission, and this was for a period of around 20 days. The baby also received oxygen therapy during this NICU admission and also received blood transfusion. There was further a history of meningitis during the first few days of life. So we proceeded to examine the baby, and we began with the anterior segment examination, which was found to be normal. The baby had the presence of tunica vasculosa lentis, and the baby also had poorly dilating pupils, which only dilated up to around 4 millimeters. So we proceeded to do an indirect ophthalmoscopic examination with a 28 diopter lens, and we also did RETCAM images of the same patient, which was done at 34 plus 5 weeks of postmenstrual age when the baby presented to us. I would like to describe the picture seen here. This is the classical picture of aggressive retinopathy of prematurity, wherein we can see that there is extensive tortuosity and looping of the vessels, which is seen. Here, in fact, most of the retina is avascular because whatever area is having retinal vessels is also in the form of loops and tortuosity. So most of the retina is avascular. And in the right eye, we also notice that inferiorly there are some hemorrhages which are present. And we can see that the macula is query not vascularized in both the eyes, which would further require an FA to confirm, but we feel that it was not vascularized over here. And there was vascularization only extending up to zone 1. So considering these features and considering the history which we got, we diagnosed this baby with both eye zone 1 aggressive retinopathy of prematurity with the presence of plus disease in the form of loops and tortuosity with query macula not vascularized. This baby was then planned for both eyes intravitreal ranibizumab injection, which we give at half adult dose of 0.25 mg in 0.025 ml, which is planned under topical anesthesia under monitored anesthesia care. So we proceeded to inject this baby under aseptic precautions in the operation theatre. And the baby was followed up first at 1 week post-injection. So the further follow-up schedule which was planned was at 1 week post-injection, 2 weeks post-injection, then every 2 weeks till around 12 weeks, and then every month until around 20 weeks after the procedure. And at each follow-up visit, the baby's retina was closely assessed for the signs of regression of the plus disease, or on the other hand, reactivation of the disease, and also to assess the vascular growth which had happened after the injection. So this image was taken at 6 weeks post-injection at a postmenstrual age of around 40 plus 5 weeks. So here we notice that although the condition is much better than it was initially, we still notice that the vascularization has only extended up to zone 2 posterior, which is definitely an inadequate vascularization and an inadequate response than what we had planned for during the procedure. And I've shown with arrows, with red arrows, how much the vascularization has progressed. And if we closely look at the picture of the left eye, we also notice that there are some signs of reactivation of the disease also, although it is early reactivation. Here we see inferiorly that there is the presence of some vascular looping and tortuosity which is seen. And so we further planned, in view of the inadequate vascular regrowth and because of the presence of early reactivation, we planned that the baby should undergo a repeat injection of ranibizumab at 6 weeks, again at the dose of 0.25 mg in 0.025 ml, under topical anesthesia, under monitored anesthesia care. So the baby has currently completed 4 weeks post-injection, and on follow-up examination, the retina was found to be growing well into zone 2 anterior currently. The baby will next be followed up at 6 weeks, 8 weeks, 10 weeks, 12 weeks, 16 weeks, and 20 weeks after the procedure. At 10 weeks after the second injection, we will again assess if there is a significant avascular area or if there is a reactivation. In case this situation does arise, we would go ahead with lasering this area, and if not, we would proceed with follow-up. So I would conclude by saying that repeat injections of anti-VEGF may be used in selected cases of zone 1 aggressive retinopathy of prematurity, especially in this case, which had poor vascular regrowth and signs of early reactivation. Thank you.
Thank you, Aishwarya. And that was a very interesting case. Very few of our cases, or at least in my experience, we have cases like this where we have to take the decision on re-injection of an anti-VEGF. But to start off with the discussion, before we go into that treatment plan, I would like to raise this question to our panelists. What are your indications for using an anti-VEGF over the laser, and why? So let me start with Diksha. Diksha is there?
Yeah. Hi, Komal, and thank you for the kind introduction in the beginning. So as the question that you have raised is, what are the indications that would be there for anti-VEGF in my practice? So I would reserve anti-VEGF for practically all cases of zone half or a posterior zone 1 aggressive ROP. And also majorly cases of zone 1 anterior, but again, for zone 1 anterior, there may be some of them which I'll still prefer to do a laser. But yes, and that will depend also on whether what is the status of the parents, whether they understand the need for regular follow-ups. Also in cases where there is a very significant tunica vasculosa lentis that is not allowing pupillary dilatation, I would go with anti-VEGF first and followed by whatever the procedure may be, just wait and watch, or if the disease regresses. So that would also be one indication of giving anti-VEGF first in my situation. And also if there is a media haze because of a vitreous hemorrhage, that would also be cases for anti-VEGF as first priority. So most of the cases of zone 1 and cases with a severe plus disease or a mat-like fibrous proliferation, there's a fleshy proliferation that is just beginning to develop, those cases would also be considered for anti-VEGF early on in the course.
Okay, so as I understand correctly here, it's basically on very specific indications, and you do not use anti-VEGF for all cases of ROP. So if I may bring Dr. Samira as well. Dr. Samira, if you want to add on to certain indications, or do you follow the same protocol?
Hi, Komal. Yeah, my baby is crying. Is it audible?
Yes, absolutely. Very nicely.
Yeah, anti-VEGF injections are actually my first choice for any ROP treatment, any treatable ROP, I would say. If the baby has stage 4 AROP, then I first go for laser before doing surgery. But rest all cases of treatable ROP, I inject anti-VEGF.
Okay, so if I understand correctly, you also inject anti-VEGF in staged ROP cases, right?
Yes.
In the cases where the ROP is more in zone 2 anterior, or there you would want to do a laser first? I mean, you want to proceed with a laser rather than an anti-VEGF.
Can you repeat, please?
Yeah, I'm just asking that if the ROP, the treatable ROP is in zone 2 anterior, then in those cases also, do you prefer using an anti-VEGF?
Yes, I usually inject anti-VEGF and I wait till vascularization of anterior zone 2. And if once it reaches to zone 3, then I go for laser. Otherwise, I do not. Only for persistent avascular retina in zone 3, I go for laser. The rest all cases, I go for anti-VEGF.
Okay, so that's a different take than Dr. Deeksha. So Dr. Simmer, if you want to add something, or what is your approach on the use of anti-VEGF?
Yeah, so I would agree with what Dr. Deeksha said. So we reserve it for a very limited number of cases, and primarily zone 1, posterior zone 1, definitely all the cases. Zone 1 interior, most of them we are shifting to anti-VEGF, but if we see any fronts of proliferation, early proliferation, especially the ones that come around 6 to 7 weeks, a little later than they should. So in those, I would be a little wary, or maybe counsel them that they may need early laser following the anti-VEGF injection rather than just waiting for the vascularization to proceed. And in cases with a media haze, and in stage ROPs, zone 2 posterior and zone 2 anterior, I would prefer laser, because given the volume of patients that we handle and the amount of follow-ups that will be required for these babies, I feel much more confident lasering them and be assured that yes, I have treated them for life and I don't need to worry about the retinal status thereon.
Right. So this is a very important point that you brought up. So since you have brought this up, I would like to ask Dr. Samira this. Dr. Samira, since you are using more anti-VEGF in like a wider range of indications, do you also take into account the understanding of the parents and whether or not they understand, or do you feel that they will come for a regular follow-up post injections when you take that treatment decision into account?
Yeah, a good counseling is a must. And before you go for any treatment, whether surgery, injection, or laser, a good counseling is a must for all ROP babies' parents. And we need to, especially if we are going for injection, then need to follow up these cases frequently. That is very much required. And for that, the parents should be ready. And if we feel that parents are not, may not come frequently, then we may go for laser. But if they can come regularly, then definitely injection I prefer to laser.
Right. So I guess one of the most important take home from this discussion is that a proper counseling of all the patients who are undergoing any kind of treatment, whether it be anti-VEGF or laser, especially with anti-VEGF, it's extremely important so that they understand that this is not a one-time treatment and it doesn't end here, and they have to keep coming, and we are just doing a rescue with anti-VEGF, and we have to still wait for the vascularization, and it's a long process. And I guess that kind of a conversation with the parents is extremely important for us to have. So moving the discussion ahead, there's one question that has been put up in the chat as well, which is regarding the follow-up of the anti-VEGF treated babies. So Dr. Deeksha, what is your follow-up protocol for them, and how long do you follow up, and at what intervals, and what are the factors that you take into account before you decide on how to follow up these babies?
Okay, so as regards the follow-up is concerned, so after the injection, we generally see the child. Earlier, we used to see within 24 hours, but now we've shifted to 48 to 72 hours. By the second day, we generally do see the child. So if by any chance the child is not able to come on the 48-hour visit post-injection, then the next day, but 48 to 72 hours is the first visit. And then by 48 hours, by and large, you tend to start seeing the effect of the anti-VEGF in terms of how the pupil is dilating and whether the plus has just beginning to regress. You start seeing a subtle change. So by that time, you know that the injection probably has started acting. And so if by 48 to 72 hours, the pupil is dilating and the pus is less than what it was pre-injection, then we will call the child in a week. And then at the 1 week follow-up, again, we see what is the change from the pre-injection. And if there is a significant reduction in the pus, then we may follow up the child every 2 weekly. And as far as the follow-up is concerned, we generally tend to wait till there is reactivation. And by reactivation, we mean that there is a recurrence of the tortuosity, the dilatation, or a faint semblance of a ridge-like appearance coming up at the avascular junction. Though by and large, we don't wait till you have a frank ridge. So the moment you start seeing the return of tortuosity and dilatation, that is the time we start planning. So within the next couple of weeks, we take up the child. If the child is still, around 45 weeks, we may consider the child to be taken up under topical anesthesia. And we tend to do a fluorescein angiogram to see whether there is a reactivation at the vascular junction, whether there is any new vascularization, what is the extent of the peripheral avascular retina, is it significant enough? So if there is a significant avascularity, there is a new vascularization, there is leakage, then we will go and do the laser. Again, it also depends on the zone of the disease, though by and large, we don't treat zone 2 disease with anti-VEGF as first line. So for us, that those subset of patients, rarely are very rare. So there will be mostly zone 1. And in zone 1, there will be either posterior zone 1 and zone 1 anterior. In posterior zone 1, we know that the vascularization may not be complete with the first injection, and they tend to have a lot of avascular retina still remaining. For zone 1 anterior, the extent of the peripheral avascular retina will be lesser, and it will also depend on what injection has been used, whether you've given bevacizumab or you have given ranibizumab. So again, depending on the extent of the avascularity, we will go ahead and do a retreatment. In our situation, most of the retreatments are lasers, unless it's a very significant peripheral avascular retina. However, I have given a few second injections in posterior zone 1 disease, and I have not seen as yet complete vascularization occurring even with the second injection in posterior zone 1 disease. So I know that probably they are not going to vascularize completely, and I will have to end up doing a laser.
Thanks, Dr. Diksha, for that elaborate discussion. And so just moving on before I take up other questions to Dr. Samira, because she has a different take on that. So Dr. Samira, for you, how do you follow up, and what are your indications for retreatment, or what factors do you consider?
After anti-VEGF injection, I call the baby after 1 week. I do not call them after 48 or 72 hours. I call them after 1 week if I'm not planning for any surgery. And after 1 week, if I'm satisfied that the eye is responding to anti-VEGF, then every 2 weeks, I call them, and till the ROP is completely regressed. And once there is complete regression of the ROP, then I call it every 3 to 4 weeks, not every 2 weeks. So 3 to 4 weeks, I call them till the entire retina is vascularized. Many times we see the peripheral retina remaining avascular. In those cases, I follow up and every 3 to 4 weeks, and sometimes I take them under general anesthesia, because once the baby is more than 4 kg, it's very difficult to see the periphery in OPD. It's very difficult to restrain them. And under anesthesia, I see them, and if required, I do laser. So I do not leave any avascular retina like that. So I do laser to the avascular retina.
Okay, so thank you, Dr. Samira. But if I just may ask the question, because you increase the duration of the follow-ups once you see a complete regression of ROP. So just for the benefit of the audience here, if you can just explain, what do you mean by a complete regression of ROP? when you have treated the baby with an anti-VEGF. That's the first thing. And the second thing, do you feel, because after a certain period of time, maybe 4 to 6 weeks, the effect, the primary acute effect of the anti-VEGF will start waning off. And that is the time which is sort of more notorious for the aggressive ROP to sort of come back, or for us to see the reactivation. So do you still feel, or in your experience, have you seen that, or have you felt that the 3 to 4 weeks gap was a little longer and you should have followed up earlier, or you feel that it's like sort of okay even after 6 weeks or so?
Not 6 weeks, 3 to 4 weeks after the ROP is regressed. So regressed ROP, meaning that after 1 week of injection, we see how the eye is responding, meaning that the media is getting cleared, and the vascularization of the iris, if it was there before, then it is regressed, and tortuosity, dilation, those are also responding, and the vasculature is coming to its normal caliber. So these are the signs of regression. And once the ROP is regressed, if it is not a staged ROP, then you will see that it's a there is no vascular tortuosity or dilation, and though it is not completely vascularized. And if it is a staged ROP, also you can see the neovascularization, those are in the vitreous cavity, those are regressed, and you will not see the plus sign also. So these are the signs of regression, and once it is regressed completely, there is chance of recurrence. But these babies, you can see, you can call them every 3 to 4 weeks instead of 2 weeks. Otherwise, it is very difficult to call so many babies. 3 to 4 weeks is enough, and we have a counselor for these babies to call. And if a baby is missing, then we call them and remind them. The most important thing is most of the areas I have seen, delivery happens in one house, and after maternity leave, the mother and the baby, they go to a different house. So that is very important, and we need to tell them this is a particular person you need to show in that particular place. So that message should go to the parents.
Right. So I guess that's a very important thing, again, important take home, that, that the parents should understand that even if they're changing the city, or even if they're traveling, they have to sort of communicate with their doctor to make sure that the follow-ups don't get missed. And they have to understand the importance of the follow-ups. And I really like the strategy of having a counselor or having a helper who can help you track all these babies and make sure that we call them, and we don't basically in order to minimize the lost to follow-up sort of babies. Now, taking the again, because of lack of time, we have to move ahead. So let me take Simmer's comments on the retreatment strategy again. So Simmer, if we discuss this case, and if I can have Aishwarya just share the fundus photos. Dr.
Sure, just a minute.
Yeah. So Dr. Simmer, would you treat this particular case in the similar manner that was done, or would you have a different take? Would you want to observe for some time more and confirm the reactivation, or do you feel you would have followed the same thing? And again, your considerations on re-injection, of which babies you consider a re-injection.
Yeah, so I think the initial treatment was definitely is what I would have done, seeing a posterior zone 1 disease. So injection is anti-VEGF injections are definitely the way to go there. So just a thing on the follow-up also, like you said, I do prefer to have a 24 to 48 hour follow-up, because especially I think one point we did not discuss is that we are allocating these doses in a lot of these babies. So sometimes while allocating that, it is possible that one eye may receive lesser or actually no dose because it remains in the hub of the needle. So I've had at least a couple of cases of those in which one eye had a very good response and one eye did not have a good response or did not have a reduction in plus disease, and I had to re-inject that eye within the next 1 week only to get that response. So that initial follow-up is important. So once I see that the plus disease goes down, the vessels actually start growing once the anti-VEGF is gone. So this is also something we need to understand, that anti-VEGF is actually detrimental for vessel growth. It just causes the reduction of the disease and stability of the disease. And then it gives the body the time for the natural mechanisms to cause growth once the anti-VEGF effect goes away. So it's important to monitor at that point. And once on serial follow-up, I see that the tortuosity is increasing or I see any form of stage forming. So my criteria is usually zone 1. If zone 1 is vascularized, I would definitely want to laser that eye rather than re-inject that eye. And that is how I counsel the parents also, that we'll wait for the vascularization to proceed, because we are injecting only zone 1 babies, and that too mostly posterior zone 1. So that is the criteria that we follow. And if zone 1 is vascularized, I would prefer to laser if there is a reactivation, any appearance of tortuosity, hemorrhages, or a stage forming.
Okay. Okay. So there are definitely a few questions in the chat regarding the signs of reactivation, and if Dr. Diksha can take that up, especially commenting on whether or not do we feel that tortuosity is a sign of reactivation.
Yeah, so actually, we know that sometimes the tortuosity tends to remain even after treatment with anti-VEGF. Actually, it is just the tempo, the course. So what we see from, if we have serial images, we'll start realizing that what is the change from the baseline post-injection and on the follow-up. Like if you see in this picture, the right eye versus the left eye. But if we compare it from what it was just before that, we see that it is much less. In fact, the loops have opened up, especially if we look at the right eye nasal. And if you compare the right eye now after the injection, similarly the left eye, we see that those loops have actually opened up here. Similarly, in the left eye, the tortuosity is much less as compared to the previous visit. What is going to happen if there is when from this follow-up, after we've seen the response, if there is a return that is coming up that was not there previously, so that time we start thinking that maybe these are early signs of reactivation. And as far as the ICROP3 has really defined, and so the participants can go back and go through what are the definitions. So it has clearly mentioned that what are the signs of reactivation, and it does include the return of tortuosity and dilatation, as well as the reappearance of the ridge as the signs of so it's not just one point. Actually, you really have to look at the tempo of what has happened over time and then make that decision.
So that again is one of the most important take home, that you see the tempo of the disease. It's not just one thing, or just seeing one toxicity or one vessel which is slightly more dilated. You always have to compare it with the previous picture, and that is where having fundus imaging is very important, especially in these cases where we inject anti-VEGF. We are sort of running off time. And so Dr. Puneet had another question in the chat, that similar thing, that he has noticed that even after laser, at 1 week post laser, he still feels that the tortuosity still remains. And so whether is it a sign of persistent disease needs a re-injection, or we should wait for a few weeks? If Dr. Samira can take that.
Yeah, Komal, in this particular case where re-injection has been done, I would have waited more weeks. I had done only one re-injection, and I felt that the avascular retina, it doesn't go completely with re-injection. Rather, if there is an established appearance of the recurrence of the disease, then only we should consider second treatment, additional treatment like laser, or there is persistent avascular retina, then you can go for laser. Otherwise, re-injection, we need to think twice before we administer injection. And you asked about
Post-laser regression.
sorry,
Post-laser regression, yeah. If the participant has a question that the tortuosity or the dilatation still remains after 1 week post laser, so you still wait, or
definitely I will wait. And we need to know actually whether the eye is in the process of regression or there is recurrence. So we need to see serially, and we need to know that this eye is responding to the treatment, whether it is laser or injection. So we need to closely observe the vessel caliber, looping, and other things. Whatever you inject, whether you inject or do laser. So it's not that 1 week you will see complete regression or everything will go. So we need to see serially, and then we decide that it is really a recurrence, it's not that the eye is in process of regression.
Right. So again, seeing the signs of regression is extremely important. And again, what I believe is that post-laser, the regression takes a little longer as compared to when we inject an anti-VEGF. So what you see 1 week post-injection is not what you will see 1 week post-laser, and the plus might still remain. But at 1 week, it's extremely important for you to look for skip areas and look for increase in traction if you have lasered. And if you see those kind of things, then an additional laser is something that should definitely be considered. Now, I'm really running out of time, and we have another very important and very nice case coming up. So I'll reserve a few questions for the next case. And thank you so much for an awesome discussion on this case. So our next participant is Dr. Arpita, and she is a vitreoretinal fellow at the Vizag campus of LVPI. So welcome, Arpita. Yeah, your slides are visible. Go ahead.
Yeah, thank you, Dr. Komal. Am I audible?
Yes, you are. Go ahead.
Yeah. I'm Arpita. I'm an vitreoretinal fellow at LV Prasad Eye Institute, GMRV campus, Visakhapatnam. Today, I will take you through an interesting case of ROP, which presented with an exudative retinal detachment in one eye. 20-day-old preterm baby born at 32 weeks of gestational age, presented to us at post-menstrual age of 35 weeks with birth weight of 1200 grams. Elsewhere diagnosed as both eyes aggressive ROP zone 1 plus disease with right eye traction banded disc. Coming to the detailed history, preterm baby with very low birth weight of 1200 grams, not cried immediately after birth, diagnosed as birth asphyxia with respiratory distress syndrome, had an NICU admission for 10 days, received oxygen therapy through CPAP, and then had a neonatal jaundice at 5th day of birth, and also received blood transfusion for 2 times. At presentation, in anterior segment, both eyes neovascularization of iris with poorly dilated pupil of 4 mm. Coming to the posterior segment, both eyes dilated tortuous vessels in zone 1 with loops and intraretinal hemorrhages, and avascular retina beyond zone 1. And in right eye, there is yellowish white patch at posterior pole with retinal edema and subretinal exudation and exudative detachment. No traction component is seen, and no clinical telangiectasia are seen. Diagnosed as both eye NVI with aggressive ROP zone 1 with plus disease, right eye exudative retinal detachment. Advised torch profile, hemoglobin, complete blood picture, and peripheral blood smear. We injected the same day both eyes half-dose bevacizumab under topical anesthesia under monitored care. And hemoglobin, CBC, peripheral blood smear are within normal limits. Coming to torch profile, IgG positive for Toxoplasma, rubella, and CMV. IgM all are negative. After 6 weeks status post injection at PME of 41 weeks, this is the fundus picture of the right eye. Firstly, retina is attached and there is significant reduction in exudation and hemorrhages got resolved and regression in dilatation and tortuosity of the vessels, and the vessels are reaching till zone 3. Left eye, vessels are reaching till zone 3 and zone 3 immature retina is noted. Both is zone 3 immature retina, no stage is noted and no signs of reactivation are also noted at this time. And we plan for further observation. At 47 weeks PME, there is a mature retina in both eyes. In the right eye, we can see even more reduction of the exudation and few hard exudates at the posterior pole near inferior arcade, and vessels are reaching till ora in temporally also. Left eye retina is unremarkable. We planned for UVA and refraction. On refraction, refractive error is not significant. It is appropriate for age and no need of glasses at present. Little bit about the literature. This is the paper presented by Dr. Komal, published by Dr. Komal. Exudative retinal detachment as an initial presentation of ROP. Among 2,500 ROP babies, only 8 babies had this initial presentation of exudative retinal detachment. Among them also 7 are bilateral. Only 1 baby is presented with unilateral exudative retinal detachment. All are well managed with intravitreal anti-VEGF, and laser was given for the only needed eyes. Anatomical and refractive outcomes are good and comparable with the staged ROP and aggressive ROP. To summarize, preterm baby with very low birth weight, diagnosed with birth asphyxia and respiratory distress syndrome, had an NICU admission, received oxygen therapy through CPAP, presented at 35 weeks with both eyes, zone 1, aggressive ROP with plus disease, in right eye, exudative retinal detachment, managed with both eyes half-dose bevacizumab, on follow-up, having a good anatomical outcome as an attached retina, no retinal folds and traction bands. And even the functional outcome is also good as there is no significant refractive error and no need of glasses as of now. Thank you.
Thank you, Arpita. Thank you for presenting that case. And as you can imagine, this is something that is very close to me. So thank you again very much for bringing this up. So I would start off with the discussion, and I would take Simar's opinion on this first. So Simar, under a situation or under an atypical presentation like this, what would be your differentials and how would you come to a diagnosis of an exudative sort of an ROP here?
Yeah, Komal, thanks for that. I think a very interesting case, and we also have seen a couple of cases presenting similarly. So given the complete history, the prematurity, and the profile that was given, I would consider the diagnosis of ROP only, aggressive ROP, in which there is probably a more component of oxygen-induced retinopathy, like where there is an extensive breakdown of the blood retinal barrier, and even the formed vessels are actually broken down by the excessive oxygen that is given over a very short period of time. And that leads to increased exudation from these retinal vessels and causes the exudative detachment as well as the hard exudates that we see in the subretinal space. So yes, anti-VEGF, as we know, is known to restore the blood retinal barrier and also in this case helped in maturation of those vessels further. So I think the management line would definitely remain the same, and especially if you see the photograph of the right eye at initial presentation, even close to the disc, you see those whitish areas between the vessels on the nasal side. And that is a sign which is very classic of oxygen-induced retinopathy, causing ischemia even in those formed areas where the normal vasculature is actually going.
Yeah. So Dr. Diksha, your take on that, would you, sort of consider any, not for this case, but similar cases, would you consider any other differential?
I think the differentials that may occur as are cases of FEVR and incontinentia pigmentae. And though this presentation is quite a rare presentation for ROP, but yes, those would remain one of the differentials. I would like the presenter to please be on the slide where the follow-up is shown.
This is the slide, or
So the
No,
next
the one
will
after
all
41,
be-
47 weeks. Yeah.
this is a
You have
porous
a-
image, which is not that clear. Sorry for the image, which is
Yeah.
there
So
are-
I don't know, because I think Komal has more experience in managing these cases. There's a question that comes to my mind, because I've seen 3 or 4 cases, not that common, but they do respond actually very dramatically to anti-VEGF. But on follow-up, the area of the exudative RD, just leaves like what you're seeing in the posterior pole, just as the exudates have started to resolve, you see that there are some well-defined patches of RP atrophy that are coming up right at the macula. I don't know whether it's visible. So I've seen that
Yeah.
most of these cases of exudative retinal detachment presenting very early on have resolved with the leaving, or whenever has been subretinal fluid, they have resolved, leaving behind a lot of RPE abnormalities, and on follow-up, a lot of pigmentary changes. So what has been your experience, Dr. Komal?
Yeah, so like this sort of works like any other case where you have a lot of subretinal fluid initially, and when it starts resolving, you will have some exudates, and the presence of those exudates and a long-standing fluid sometimes can cause a photoreceptor damage and a subsequent RP atrophy. But as the paper says, we also have seen sort of not too much, but like 8 or 10 cases, 8 or 10 babies of such a presentation. And by now they are sufficiently grown enough to see whether or not, sort of they are developing these patches. From what I remember of my series, I do not remember, very significantly that anybody developed an RPE atrophy patch over the macula. But it will also depend, I guess, on the amount of exudation that they had at the initial presentation, and on resolution with anti-VEGF, how much of these subretinal exudates we see. However, I would like to mention here that I had seen one baby with hypertensive retinopathy, which we had also published, and that baby had a similar sort of lot of fluid and cotton wool spots at presentation, along with a few hemorrhages. And that baby, post resolution of the fluid and the exudates, did develop a large RPE atrophy patch. So that is something that definitely is a possibility. And I guess the more the exudates that they remain post the resolution of the fluid would determine whether or not the development of the visual acuity post, as they grow up, would be affected or not. So that's my take. But again, it's a very rare presentation, and yeah, so it's very difficult to say. Again, so thank you, Diksha, for that question. But again, coming back to our discussion on this case, Simar did mention that these cases are probably more related to the hyperoxia-induced retinopathy. And I would like to take Dr. Samira's and then Dr. Diksha's opinion on the same. Dr. Samira, what do you feel is the pathogenesis behind such a presentation?
Thanks, Komal. This type of cases, particularly we have seen babies coming from level 1 or level 2 NICU. So you will never see these babies being treated in a tertiary center. So there is a history of oxygen therapy, definitely, and the oxygen concentration, we usually do not get exact data, but there is definitely there is something wrong in oxygenation of these babies, and you see babies coming from level 1 and level 2 NICUs. as we know that this particular case actually both outer blood retinal barrier as well as inner blood retinal barriers are affected. And you can see the first picture how the vessels are, and there are exudation along the vessels as well as exudation subretinally. And you can see there are a lot of area, retinal area looking whitish, and those are the edematous retina. And mostly there is breakdown of the inner blood retinal barrier. The endothelium is at fault, and that's the reason there are a lot of exudation, and there is ischemia because of hyperoxia. And we know that oxygen leads to obliteration and obliteration of the vessels, and that's the reason actually this kind of picture sometimes we see the retinal opacity. And this also associated with choroidal ischemia, and choroidal ischemia also leads to breakdown of outer blood retinal barrier, and all this may lead to the exudation. So in this cases actually not only exudation, we see edematous retina, and also we see vessel attenuation. And they do respond very well to anti-VEGF, as you mentioned. You are not audible. Can you unmute yourself?
Yeah, sorry. So, yeah, I was just saying thank you, Dr. Samira, for bringing out that point on vaso-obliteration and the retinal edema. And we had also seen in our series that the other two features that was very common in these kind of eyes was patches of vascular sclerosis and these patches of whitish looking retina in between the dilated and tortuous vessels, which was very different from the normal avascular retina that we see in APROP cases. So these were very well defined, and when you look at them with an indirect, it felt like sort of intraretinal edema. But unfortunately, we could not do OCT through that in these babies, and probably that would have given very good sort of information on the kind of retinal structure that they have. Just sort of taking the discussion a little more forward, and the PGI group, both Dr. Simar and Dr. Diksha, you guys are very much known for publishing on atypical ROPs, different kinds. So taking sort of your comment on what are the different, because this is a very atypical presentation. So apart from that, what other sort of atypical phenotypes do you see in your practice, and which ones are the more commoner ones? Dr. Simar, if you can take this first.
Yeah, so I think more recently over the last 3 to 4 years, I think we have published from LVP also, the blister-like ROP that we have been very commonly seeing, which is actually a posterior zone 1 AROP, in which again there is an extensive breakdown and swelling up of that retina, that is the only formed retina posteriorly, that itself swells up, and that gives a blister-like configuration. And we have seen that at even 4 weeks when there is no fibrotic component, just a swelled up retina in the vascularized part, and the avascular part is attached. And that kind of subsequently then develops a fibrous component and lifts directly towards the optic disc. And so that is a very common form of, again, mostly seen from the referrals from the outside NICUs, where there is no control over mostly the oxygen concentration that are given. So I think that is something very similar to what we are seeing in this case, but the exudation is not that extensive. But once that blister kind of settled down, it settles down with these kind of subretinal hard exudates over there at the posterior pole, which take time to go away and leave some form of atrophy also over there.
Right. Dr. Diksha, if you want to add something to the atypical forms.
Yeah, I agree with what Dr. Simar has said. And I also have started seeing the I mean, I call it the secondary TFV stock, which is again probably a late presentation of a posterior zone 1 with a very posterior location of the tractional detachment with a peripapillary TRD, mainly peripapillary with macula drag towards the disc, sometimes within the fold, and wherein there is a prominent optic disc neovascularization leading to opening up of the hyaloidal vasculature and the neovascularization growing along the hyaloidal canal and towards the crystalline lens, and almost, sometimes touching the posterior surface of the crystalline lens. And also recently, some of these children have come up with vitreous hemorrhages, not the typical red ones, but the gray vitreous hemorrhages, sometimes bilaterally. And when you operate them, sometimes you see changes similar to what we are seeing with a posterior pole showing RPE abnormalities. What happened? Maybe there was a blood retinal breakdown due to, various causes, and most of them are from level 1 or 2, level 2 nurseries, and maybe it is related to the severe inflammation, the oxygen, and the severe vasoobliteration that occurs in some of them. But yes, this pattern is definitely related to the oxygen supplementation, leading to an acute and very severe vasoobliteration, a VEGF overdrive, breakdown of the blood retinal barrier, and probably involvement of the choroid also that results in this phenotype.
Right. So thank you, both Dr. Simar and Dr. Diksha, for describing that. We have certain questions in the chat from the audience, and one of the questions from Dr. Ankit Avasthi. He says that in your experience, what do you think that in such ROP presentations, how often does complete vascularization takes place without the need of laser? So Dr. Simar, if you can take that.
I'm sorry, can you just repeat the question? Sorry.
Yeah, do you feel that these, like how often do you see a complete vascularization post anti-VEGF?
So again, since our indication for injections is mostly in the zone 1 cases, and that to posterior zone 1, so that would be very rare. In interior zone 1, we may see in up to about 30 to 40% of the cases. But in posterior zone 1, almost 90% of the cases end up requiring retreatment, mostly with laser in them.
Okay. So Dr. Diksha, if you want to add something to that.
No, I agree with what Simar has said.
Okay. So thank you again. There is another question. So there's a lot of discussion on, how to give anti-VEGF, what anti-VEGF to give, and sort of what dose to give. So those are the common questions, and that is a very common point of discussion between both the cases that we had. So Dr. Samira, if you're there, what anti-VEGF do you prefer and why? And how do you give it? Maybe she's off for a minute. Dr. Diksha, if you can take that question. You're muted, Dr. Diksha.
Yeah, so I think it depends also on where you're practicing. For example, we are in a government institute where recently, because the government-sponsored JSSK program is in place, so all infants less than 1 year of age, practically the government sponsors all the treatments. And in that program, actually, we now have the all of our cases by and large, we now have to give the biosimilar Razumab. So ranibizumab. So earlier we were we don't give bevacizumab too much. That's the hospital policy. So we were giving ranibizumab in the form of Accentrix or Lucentis, and we have now also started giving Razumab. I have given aflibercept also in a few cases, and I have seen good response with aflibercept also. So that's the generally we give half dose of ranibizumab. And aflibercept, I gave 1 milligram, but I think after the Firefly study, we have to come down to 0.4 milligrams of aflibercept. And for bevacizumab, actually, that's the molecule wherein you need to really worry about the dose because of its systemic absorption and this. So I think Dr. Samira can give her experience if she's using bevacizumab.
Yeah, Dr. Samira, your experience on the kind of anti-VEGF that you use in these babies and why?
I have given only bevacizumab. I have no experience with eccentric, ranibizumab or any aflibercept, only bevacizumab and
How do you feel the vascularization is post bevacizumab? Have you seen complete vascularization in a good number of patients, or you feel that most of them do require some zone 3 laser?
well, 50% I would say they require laser. And 50% you will see there is complete vascularization depending on the presentation.
Okay.
So, we have not analyzed our data, but in an average, I can say.
Okay. So just, sharing my experience here, because I was at LVP a couple of months back, and for the past, I guess, more than 8 years or so, while I was managing ROP, I would give just bevacizumab, again, hospital policy. And my experience was pretty good with bevacizumab. And I guess about almost, as Dr. Samira said, almost around 50-60% of them would require laser, but there were quite a few of them which would not require a zone 3 laser as well. And we would see some babies with complete vascularization. Now I've moved to a different setup in Lucknow. And here the use of Avastin is not very widespread, even in adults. And now I've started injecting a lot of ranibizumab in these babies. I must say that my experience is pretty different. I do see more recurrences as compared to what I used to see when I used to inject bevacizumab. But again, I have not analyzed the data, so it's a personal experience that I'm speaking of. As far as the efficacy is concerned, I guess we can all agree that all of these anti-VEGF are efficacious in ROP, and we do see very good response. It just sort of comes down to the cost, and it does come down to the recurrences as well. Now we have another question from Dr. Puneet, and he's asking, in zone 2 stage 3 ROP, which presents with early fibrovascular stalks extending into vitreous all around, do you prefer to inject immediately and then laser, or directly laser? So Dr. Simar, what is your take on such patients?
So definitely with the presence of fibrovascular stalk, and that too, that is 360 degree, I would definitely want to laser directly, especially in zone 2. If I have a good view, I would prefer to do a posterior barrage laser also, about a couple of rows just posterior to the fibrovascular proliferation. And mainly because I want to delay that fibrovascular crunch that is going to happen absolutely suddenly with the anti-VEGF, because that is going to drive off the VEGF immediately and increase the fibrotic factors and increase the fibrovascular proliferation, likely progressing the TRD. And if I have a good view, I would prefer to laser that directly rather than going for anti-VEGF.
Okay, thank you, Dr. Simar. I am really running out of time, so just one last question to all three panelists, and we will start with Diksha, then Samir, and then Samira, and then Simar. On what is your treatment protocol for PAR, or persistent avascular retina? Do you treat, do you observe, or do you, sort of laser, or do what? Dr. Diksha, you first.
Well, if it is significant enough, I'll do a laser. Yes. If it is significant more than 2 diameters or zone 2 and beyond, I will do a laser.
Okay, Dr. Samira.
I do laser. I do not leave any avascular retina, because I know that we have like lattice, and in future there is a risk of rhegmatogenous retina detachment. So I do laser to all persistent avascular retina.
Okay, Simar.
I agree. So I think one thing that we didn't discuss is the role of FFA, maybe for the next session. So that kind of plays quite a good role here. And if I see more than 1 disc diameter of avascularity beyond 55 to 60 weeks of post-menstrual age, I would like to laser that. And mostly on FFA, you find more activity than what you are seeing clinically. You would see leakage once you have more than about 2 disc diameter of PAR left over there. And so definitely laser would be my choice to go over there.
And
Mm.
also, I think it becomes extremely difficult to see the peripheral retina as the child is growing up. The child is struggling in your clinic, you can't depress. So it becomes very difficult. So I think it would be
Beyond
better.
45 weeks only
Yeah.
that happens. It's very
Yeah.
difficult beyond that.
So at least we all agree on that fact. Laser and sleep better, all of you. So again, thank you very much. We had an amazing discussion with all our amazing panelists, and thank you both the presenters for bringing out such nice cases to us. It was a very nice discussion, and it's very nice to see all of you, especially Dr. Samira. I'm seeing you after such a long time. So hoping to have another session on ROP, and hopefully to bring on some more advanced cases and probably some surgical cases as well. So stay tuned, all of you, for another session on ROP. And thank you very much for taking up time and being here with us for all the discussion. Thank you, everyone. Dr. Avnish, if you want to close.
Yeah. Thank you, Dr. Komal, for moderating this session, and thank you all the panel with the presenters, and also the audience which actually have been here. So we'll come back soon. Thank you so much. Thank you. Take care. Good night. Yeah.
Thank you.